medical student at the Seattle VA when he was in medical school. And Kevin went on after graduation to do a residency in family medicine at the University of Colorado in Denver with an extra and specific emphasis on obstetric. After that, Kevin worked in the Indian Health Service for many years. Most of that time was at Chinle, Arizona Reservation in Canyon de Chelly, where he rose to the position pretty quickly as the medical director of that Indian Health Service hospital. After that, Kevin moved back to the Northwest to Topanish, Washington, and worked at the Yakima Valley Farmworkers Clinic. And I remember when he invited me to come out there and do a talk, I was astounded and amazed at what a beautiful facility it was, because in the day, I remember on a rural health rotation, I went out to Yuba City, Arizona, when the Farm Workers Clinic was a bunch of trailers out in a parking lot. And Kevin may tell you the story of how the Farm Workers Clinic, at least in Washington State, rose to be an important entity in healthcare delivery in the Yakima Valley, specifically. Little to many people that they didn't realize, they were the only ones that could, because they had a group practice, could underwrite obstetric care malpractice insurance policies, and were the umbrella for even the private providers of obstetric care throughout the Yakima Valley. After several decades of working at the Yakima Valley Farm Workers Clinic, Kevin moved back to Seattle for a brief interlude and worked at the East Side Community Health Center, and then returned to Central Washington. City life not being his cup of tea for a reason or two. He moved to Ellensburg and has now been working at the Community Health Center there. And just to underscore, this is an individual who I think from the get-go and inspiration has seen his career in medicine as a public service and has worked in the public sector throughout the entire 30-some years. So it's with great pleasure, Kevin, that I introduce you and ask you to just tell us a little bit about yourself and how you came to your career and where you are now.
Thanks, Hugh. This is a real pleasure to be asked to share this story with anyone. I can barely get my children to listen to my recollections. So I grew up in central Illinois, and my father was a small businessman and had not finished high school. And I went to college having no idea what I wanted to do. After a couple of years I need to tell you that I grew up the product of Catholic schools for 14 years. And I think that whatever sense of social justice I have, I would attribute to probably my second grade catechism class, where I was basically instructed that I had to walk the walk, that talking the talk wasn't enough. And I was really pleased when Geraldine Ferraro was asked, when she was running for vice president with Walter Mondale, what motivated her to dedicate her life to public service. And she talked about second grade catechism. And I thought, okay, I've just been validated. So I did 2 years at St. Louis University, but dropped out because I wasn't sure why. I was still in college, and made my way west and finished up at Reed, and I was an English major. I ended up then in the Olympic Peninsula, where I set choke for a while on a logging outfit out of Forks. I had friends in Olympia because there was this new school there called Evergreen. And I went and hung out there for a while, built a cabin in the woods, but slowly started to think that I might want to do something that served the community. And I thought about teaching. I actually volunteered in a public school in Olympia. That didn't turn me on. I made friends with some folks who were paramedics and who were going to go on to become physician assistants. And I thought that sounded kind of interesting. So I learned that I had to get some clinical experience, because at that time, that program was really for training medics from Vietnam to re-enter the workforce in America. And I didn't have any experience at all. So I volunteered at a farm worker clinic in Woodburn, Oregon, and got some experience there, and then went to Yakima, Washington, and volunteered in a community clinic there. And slowly I was basically told by a physician who came to sign the charts of the nurse practitioners who worked at that clinic that I should not bother with becoming a PA. I should just go to medical school. And I said, well, I'm not smart enough to do that. And he said, oh, sure you are. You can, go do it. So I went to Evergreen. I did, because Evergreen says, at that time, I went there and I asked, so can I get into medical school if I come here? And they said, yeah, there was a person who got into medical school a couple of years ago. And that was enough. I said, okay, that sounds good. So I went to Evergreen and applied to the University of Washington. And I have to tell you that I struggled my first 2 years. I did not do well with multiple choice questions, the fire hose of information that I was asked to assimilate. I would have to say that my salvation in medical school was when I did my first clinical rotation in July of my, the beginning of my third year. And that rotation was trauma surgery at Harborview. And my third year resident was this guy named Hugh Foy. And Hugh and I bonded pretty quickly. Hugh would grab me at about 10 o'clock at night when we were on call, and he would give me $10 to go out and buy a 6-pack of beer at the corner and he would have the team meet in his call room. So we would have trauma beers because we knew that we were going to be up all night. So everybody got to drink one beer and then go back to work. I want to just take a minute to say that the authenticity and the generosity and the dedication that Hugh modeled to everyone is perhaps the rudder that I have used to keep my boat straight for the past 39 years. So thank you, Hugh.
You're welcome. That was officially sanctioned by our chairman, right? That was a prescribed dose: 1 beer, 1 person, 1 night.
When I was at Evergreen trying to do all the pre-med science, I also got very interested in the social justice aspect of medicine and became a fan right away of Ron Dellum's and his bill for universal care in America, and had been a proponent of that for a long time. But then something else I want to share with you that happened while I was at Evergreen. I went back to visit my family in Illinois and heard about this. I'd read about this guy in a newspaper called In These Times, which used to be one of the left-wing weeklies that was available even in Olympia, Washington. And I read about this guy named Quentin Young, who was at Cook County Hospital. So I just got off the train in Chicago on my way home and went to Cook County Hospital and asked where I could find Quentin Young. After some wandering around, I found his office and knocked on the door. And he spent probably 2 hours with me talking. During the course of that time, his son was coming back to town on a train. So he said, come with me. And he took me in his car to the train station, picked up his son, dropped him off, and we kept talking. But he took me into a lecture hall and he marched down to the front of the room and he said, sit down in the seat in the lecture hall. He said, I want you to remember something. If you get into medical school, every day that you sit in that seat in a lecture hall, you have to remember there's 3 or 4 people who are just as qualified as you to sit in that seat who didn't make it into medical school. And you're responsible to them to do right. I would have to say that stuck with me as much as Hugh's influence through the course of the years. After medical school, I went to University of Colorado in Denver and became really attracted to obstetrics, almost jumped into the obstetrics program, but didn't. And I was really frustrated because they would not train me as a family medicine doctor to do C-sections, because they said, well, you don't need to do C-sections. There'll always be obstetricians to do them. And I said, well, what if I'm in a place where there aren't obstetricians? And they didn't have an answer to that, but they just ignored me. So at the time in Gallop, New Mexico, there was a pretty busy obstetrical practice at the Gallop Indian Hospital because it was kind of the tertiary hospital for the reservation. And they were more than happy to train family medicine residents to do C-sections. So I went there for a month on an elective and did, I don't know, 25 C-sections in addition to delivering a massive amount of babies, and completely fell in love with the culture of the Navajo people. Then went to the Navajo Nation, to Chinle, which was a brand new hospital in the middle of the reservation. Chinle is the service unit, serves, I don't know how many 100 square miles. It serves a population of about 40,000. There was at the time, a 40-bed hospital there. I was recruited to do obstetrics along with the real obstetricians. And the way their practice worked, midwives did the normal deliveries. The obstetricians took care of the complications and did the C-sections. So for a few years, I was in that rotation, and then I did hundreds of C-sections and delivered hundreds and hundreds of babies, and always, we were on call to do the complications. I became the medical director by default because everyone else took a step back and I was left standing and in front, and took on that responsibility and for a few years. And then the last year that we were there, I did obstetrics again full time, and I met and married my ex-wife there. She's an obstetrician, and we looked for somewhere to go because there were 3 obstetricians in that service, and we were having trouble replacing people. And we had one locum and one other obstetrician who'd been there 3 or 4 years. And she told us that she was leaving as well. And we reached out to the area office and asked them for help. And they basically told us it was our problem. And we felt like this could become an untenable situation where my ex-wife was the only obstetrician trying to keep locums in line and manage the entire department. And we had 2 young daughters. We also realized that while Chinle was a beautiful place that we loved, it was pretty isolated. It was 90 miles across a mountain pass to get to a Walmart or a drugstore. It was also 90 miles to get to a paved airstrip. And I was in the back of an ambulance many times using an anesthesia bag to ventilate newborns who needed to be transported to an NICU facility. And I can tell you that was a scary 90 miles every time I did it. But there was no library, there was no swimming pool, there was nothing there. This is a picture of the edge of Canyon de Chelly, which was it's about 4 miles from where we lived and 4 miles from the hospital. It's a dramatic place, and it's a dramatic culture. And it was a privilege to be allowed to be there for the time that we lived there. I was lucky enough to be invited to traditional healing ceremonies by people who were healers and got to participate in that. It was a profound experience. And I think if we hadn't had children, I could have imagined staying there forever. We went to Greeley, Colorado for 2 years, thinking that might be a nice next stop. My ex-wife joined a family medicine residency program as an obstetrician, but really did not gel with the male obstetricians who were the predominant folks in the community. And she said, because she had been working with women, and she said, I can't do this. I don't want to do this. So we, at the time I was in the Commissioned Corps still from the Indian Health Service, because if you were a couple, if one of you was a commissioned officer and one of you was a civil servant, you kind of maximized your benefits as a couple. So I joined the Commissioned Corps and wanted to stay in the Commissioned Corps. So we found this community in Central Washington in Topanish, and I interviewed for the Indian Health Service clinic there, and she interviewed at the farm worker clinic. But when I got to the Indian Health Service clinic, they had stopped doing hospital medicine, and I was not ready to give up obstetrics at that point. So I joined the farm worker clinic as well. And I worked there for 23 and a half years. I was the medical director for several years. We had a busy obstetrical practice, and the 3 family medicine docs, we were lucky enough to have a wonderful working relationship with the 3 obstetricians, so that we had a group practice, which meant that when we were on call for the entire practice and had a backup if we needed to go to the OR. So I was managing very high risk obstetrics and doing 80 to 100 deliveries a year. And it was kind of a crazy way to live when you think that both me and my ex-wife were doing that call and trying to raise now 3 daughters. And it was pretty almost overwhelming, but it didn't allow time to do much else besides work and parent. I got involved with patient-centered medical home implementation. And started to do more and more of that, and basically scaled down to 50% clinical practice, and was doing the patient-centered medical home implementation about 50% of the time. At the time, Farmworkers Clinic had maybe 12 or 14 clinics in Oregon and Washington. What had happened was that because Farmworkers was successful in its administration and operations, the federal government was asking it to take on these failing community health centers in other rural locations in Southeast Washington. And that's how they grew, basically, to be a behemoth in the CHC culture of Washington state. My ex-wife and I didn't last after our daughters went off to college, and we divorced, and she said, well, I'm staying, so you have to leave because I'm not done practicing yet. So all my daughters were in Seattle. So I came to Seattle and thought I would find work somewhere, and ended up interviewing at the health department and meeting this guy named Colin Romero. Was lucky enough to connect really quickly with Colin, and we realized we had very similar eccentric backgrounds. And I worked at Eastside Clinic for 3 years, and I became the medical director at that clinic as well, and was lucky enough to meet someone who I wanted to pursue a relationship with, and she was living in Ellensburg. So I moved to Ellensburg and joined the community health program in Ellensburg, which is the rural clinic of the residency program, Central Washington Family Medicine in Yakima. And I've worked here now for 5 years and will be retiring in about a month from that job, but also from medicine. I think that, well, when I was a resident, I know I became involved in the political campaign of a guy named Federico Pena, who was a lawyer who ran for mayor of Denver and won. He went on to work in the Clinton administration. I think he was a Secretary of Transportation and then a Secretary of Energy. I also, when I was a resident, thought about taking whatever fledgling obstetrical skills I had and going to Nicaragua to work after residency. In fact, I thought I would go to the reservation and work for a year and then move on to Nicaragua. But life intervened, and I fell in love with the Navajo reservation and fell in love with a woman, and that never made it to Nicaragua. I don't think I was politically involved formally until Barack Obama ran for president in 2008. I remember pretty well being at the Democratic caucus in Topanish. Topanish is a small agricultural town in the Yakima Valley, south of Yakima. And when we lived there, there were about 7,000 people. It was about 85% Hispanic, 10% Native American, and 5% Anglo. So the caucus was this incredible mix of people. And it was just one of the most politically exciting experiences I've ever had. So I worked with the Obama, I canvassed and did phone calls and all of that stuff in 2008 and in 2012. Can't say that I remained politically active formally until 2016, when I campaigned pretty heavily for this woman who was a pediatrician out of Issaquah named Kim Schreier, who was running to unseat a Republican. The congressional district that got redistricted from the east side of Bellevue to the Columbia River. It's this long, skinny rectangle. And I campaigned hard for her and knocked on doors in Ellensburg for her and Hillary Clinton. When Donald Trump got elected, I felt unmoored and really struggled emotionally with what had happened, and tried to find a place where I could, who could I turn to feel grounded? Because it seemed to me that we were entering this dark place, and it was not clear how long we would be traveling in that dark place as a country. And I turned to the African-American canon and started reading James Baldwin and W.E.B. Du Bois and all of the other profound thinkers and writers, because I felt like besides the Native Americans who we tried and almost succeeded in assimilating, in the African American population has probably been the recipient of the most violence of our society. And if they've found a way to endure, maybe there's some lessons in there for the rest of us. And I actually continue to think that's true today. And so I became more and more politically active, supporting people, and was very involved with phone calling. I got excited by a woman named Corey Bush, who was a nurse in St. Louis, who was very involved in Ferguson and then decided to run for the US House seat for North St. Louis, which at that time was held by a Democrat. And I made phone calls for hours and hours and hours over the summer. And she won her primary, which was essentially a walk into the general election. So I continue to think that racism is the original sin of this country and this society, and of my people, and that we have to acknowledge how this country was founded and how it continues, and we have to choose sides. That's about as much as I wanted to say. Hugh and I had a nice discussion briefly about some science that has been done and has been contested around the generational effects of deprivation, economic deprivation, and structural racism in this country manifest in telomere length shortening, and how it affects people's genetics and how those effects pass on generation to generation. And to me, it's a really interesting connection between sociology and biology about how profound the effects of what we have done to other people, how profound it is. I'll stop there. I'm happy to entertain any questions. I think Hugh had a couple questions he wanted to ask me.
Just a comment first, and I noticed there were some younger people in the audience tonight, and there's an interesting legacy. Those of you who don't know is Quentin Young was one of the founding members of PNHP, and those of us who were privileged to know him personally and revere him as a mentor and guide, he was an amazing human being. And he was one of the group from the Medical Committee of Human Rights, which was basically the physicians' arm of the civil rights movement back in the 60s. And whenever Martin Luther King would come to Chicago, Quentin Young was his doctor and was close by, and whenever he needed any medical care. The other legacy I think Kevin, that you exhibit is that of kind of a local Quentin Young, and that's Paul Monahan. And Paul Monahan, who just passed away in the last year. Paul was an inspiration, and he worked in Topanish for a long time. And he was an inspiration to some real wonderful people who went on to help in a lot of ways. And the people that come to mind that went through and worked with Paul, one was Pat Fleet, who was our version of House, but a much kinder human being, and a dedicated nephrologist at Harborview, and as well as Erica Goldstein, who was the founding head of the colleges program and internist at Harborview. And Erica was sent to Monahan when she was discouraged and ready to quit medicine. And I think it was Fleet says, well, go out and work with Paul for a month or two and then decide, but don't just quit now. Go meet Paul Monahan and Frank Barron and a whole list of people who were in the public health service, as was David and the Indian Health Service, all filed through there. So your legacy continues for your leadership. The one question I had is, Black people and Native American people have been, and Hispanic people, and in reality, a lot of a good proportion of the Hispanic people who came here as farm workers, in fact, are native indigenous people They just come from Mexico and speak Spanish and have Spanish surnames to a large degree. So in those two groups of people, or 2.5, 3 groups of people, the COVID pandemic has affected them disproportionately. And it's got to be more than just simply the immediate effects of the social determinants of health. If you look at Herman Cain, who was the head of the Republican National Committee, who was an African-American person, surely in his recent life, he had good access to care. And I think that's what kind of spurred this idea of that there's something more to the susceptibility of diseases. I mean, the average Yupik, it said, in Nome, Alaska, the native people up there, has 5 courses of antibiotics per year. And that was told to me 30 years ago when I went to give a talk up there in 1984. So Kevin, what do you think are the main causes of the pandemic's disproportionate effect? And what are the main challenges to the people and providers in rural America to help these people get care?
Well, you're asking 2 really different questions. Let me try to address the first, but I want to say really clearly, I don't feel any more prepared or educated to answer that question than any of you participating. So I don't pretend to have an answer. I've become really involved in implementing a screen for adverse childhood experiences into clinical practice, as well as screening for social determinants of health in clinical practice. To me, the totality of a person's context determines their, I think, susceptibility to disease. It affects their biologic resilience. I feel like that says it all. But I would want to ask others of you what you feel about that. I don't have any corner on that. I don't have an insight into that you all don't have. I know that you've all been thinking about the same thing. In terms of what to do for rural America, well, what I've dealt with my entire career, well, let me say, first of all, my experience at the Indian Health Service was socialized medicine. If somebody needed care, they walked into the hospital, they got care. There was no wallet biopsy done. There were no insurance cards to review. That just was not part of your reality. All you did was take care of people. And if people needed tertiary care, you called an airplane and you got them on the airplane. And if the airplane couldn't land because the landing strip was muddy, you threw them into an ambulance and you got them to a paved airstrip, or you had to take care of them. I mean, I remember the first time that the guy who lived across the street, who was an internal medicine doc, grabbed me in the hospital because I was on call, and he said, "Have you ever done pericardiocentesis before?" And I said, "No." And he goes, "Well, come on." And off we went to the ICU to put a blind needle into somebody's pericardium to suck out the pus so that their cardiac output could come back to normal. You had to do things that you hadn't even read about before, because if you didn't do them, the person was going to die. There was nobody to call on the phone. What I want to say is that when I left the Indian Health Service, then the cold reality of what rural healthcare was for people became, it was a smack in the head. The people that I took care of at the farm worker clinic were not citizens. They had no access. The adults had no access to care. The children had access to care. The pregnant women had access to care, and we could get them whatever care they needed. But the adults, I was on the phone to the cardiologist in Yakima trying to figure something out, because the only place they could get into was Harborview. So we had to get them, if we got them to Harborview, they could get taken care of. Short of that, they were not going to get into a hospital unless they showed up in the emergency room, and maybe then they would get care. Today, since the Affordable Care Act, those people who are documented have access to care if they can afford it. The patient population I have here is largely Anglo. Most people have care because of the Affordable Care Act. Does that mean they have access to care? No. It just means that their care theoretically is paid for, but it's still very difficult in Ellensburg to get somebody specialty care. We send people to Harborview all of the time because there's essentially nowhere in between to go for a lot of people. So what I see is we need a dedication to say everyone needs access to care, but then how do we change the economics of the situation so that the nephrologist in Yakima is encouraged to open a small clinic one day a week in Ellensburg and see patients who need nephrology care? How do we configure Medicare for all in a way that ensures that people have that access wherever they are? That requires a change in culture and change in medical culture. And we're just at the very beginning of all of that and have the opportunity to lend our voice and our shoulder to the effort, I think. But again, I'm interested in this being a discussion.
Getting just briefly on Quentin Young, he's actually the godfather of our chapter here. Hugh and I were lucky enough to spend a week in Cuba with Quentin on a medical delegation looking at the Cuban healthcare working system. I mean, the healthcare system down there and how much different it was and how people-centered. And Quentin says, you guys are from Seattle and we heard it's such a liberal place out there. Why don't you have a chapter of Physicians for a National Health Program? So when Hugh and I got back, it was 2006, we started a chapter along with Erica Goldstein. Quentin came up here a couple of times to be the main presenter at our annual public meeting we used to hold them at UW. We're at a historic inflection point, I think, with what happened in Minneapolis yesterday. And, we were all gripped with that and are still gripped by it. Is this going to be a sea change? And how can we make it a sea change and not just another episode? There's so many other social justice systems that are kind of in the same category that need system change rather than tweaking the current system by giving a little more money here and there, basically keeping the medical industrial complex in place. So this meeting was about rural health care and Medicare for all, but I think the stories that you were giving us here was probably more interesting. And we all know that rural health suffered under the conglomeration of the need for profits and privatization of many of the facilities there. Really, the only way to save rural healthcare across the country is with global budgets for these smaller hospitals and clinics and stuff in rural areas that are suffering because they don't have the money, and their patients, they take care of poor people, and those people don't have the money. So the savior of rural health care would be Medicare for all, a la our own Pramila Jayapal's HR 1976. But I think we could use what happened yesterday as an inflection point to guide the rest of our conversation here, because I think this is what's hot, and we need to know and develop our ideas about how we can continue to push the systematic racism, because there's a chance that we can continue to make progress with this. And there's a whole lot of people across the country that are on board with it. And
what strikes me is that what we're really talking about, and what Kevin has been talking about, is the need to shift our thoughts about the healthcare system into a public good, part of the public infrastructure. And then, Kevin, that would solve some of the problems of how do you get nephrologists to open a clinic or come up one day a week or whatever to Ellensburg. They wouldn't have to worry about, will it make money? It would be a decision made by the larger community, perhaps a Washington state administrator, a national health system, healthcare system that would allocate money to allow the nephrologists to do that because it was needed. I keep thinking about my visits to not rural, but small town France in Thonon-les-Bains, which is a sister city of Mercer Island. And I've been there a couple of times on a delegation. And the last time I spent some time talking to the CEO of the hospital there in Thonon-les-Bains. And it's just entirely different, where the powers that be in the département that Thonon-les-Bains is in make decisions about how much money is needed and where it should go and what kinds of hospitals and clinics should be built and staffed. And then these things happen. And that's what happens when you have a completely different view of what the healthcare system is. It's not a business model, it's a public service model. And Kevin, you have worked in a public service model, which was the Indian Health Service, so you know what I'm talking about. But we need to have that become the model for the system writ large.
I thought this afternoon I saw online, as you guys know, one of my passions besides just general universal health care is what it does to the disabled community and to their families by not having universal health care because of the cost of their overall health over the course of their lifetimes. And but one of the things I thought was very positive just this afternoon was I guess it was the House Judiciary Committee meeting today, and African-American Congresswoman from Florida, whose name is escaping me, who had a 27-year career in law enforcement, was talking, and Representative Jordan from Ohio, who's a Republican, whose specialty appears to be interrupting people, interrupted her as she was talking about the importance of starting to take a fresher, serious look at truly being a congressperson and making decisions based not on sound bites and fundraising, but actually looking at issues in a meaningful way. And she did not let this man, this other congressperson, intimidate her. And she just said, you know, basically, apparently she smacked her hand on the desk and said, enough. And that's kind of the way I feel after the same period of time, Dr. Walsh, that you've been out of med school. You and I graduated the same year, and I'm also from Illinois. And I am also familiar with Dr. Young, though I never met him personally. I'm just tired of Congress, both parties, but more recently in the last 5 years, the Republican Party treating policing and healthcare as a soundbite. There's no substance. They have truly been the party of no. They shoot down everything, but propose nothing. And I'm hoping that the George Floyd verdict will embarrass some people enough. Embarrass isn't the right word. Will maybe make some members of both parties, but particularly the Republican Party, start once again becoming representatives of the public, not just of their own desire to stay in elective office, and actually start making the concept of looking at social issue legislation writ large on both the state and national stages a true discussion, working towards a solution and not just a never-ending spinning of wheels.
So Kevin, I just got through reading the book that's hyped as the best book ever written about Medicare for All, A Citizen's Guide, with a great foreword by Bernie Sanders and Pramila Jayapal. There is not a single figure or table of hard data in that 348 pages. So my question to Kevin is, do we know of any book that's not 340 pages, succinct, but with hard data, which you can get on those wonderful graphs that the PNHP have on their website? You would think that you need some hard data, comparative data. I remember one graph that blew me away was the rate of increase of administrative costs in Canada versus the United States. It's just amazing what hard graphs and data can do. So my question is, do you know of any, we have a need for somebody to write a more compact book that's accessible to everyone, not 348 pages, but has some hard data. And I'm sure it's freely available if you made a request from PNHP National to get some of their wonderful collections of their PowerPoint. I don't know of any quite like that here, Kevin. Do you? No, there's an urgent need for that.
Ralph Nader has had a guest on his show who taught me what I know about Medicare for all. You know, the fact that in 2 years, everybody under 19 over 55, 2 years later, everybody else, first $30,000 income, no cost. You have to earn up to $300,000 a year before your federal tax increase starts creeping up to 10% of your income. You just go to Ralph Nader Radio Hour and find the archives and just put in Medicare for all. This guy, he wrote a pamphlet. And he'll give it to you and to everybody.
First of all, thank you, Dr. Walsh. And thanks for PNHP and everybody for being here. One quote that you used, Dr. Walsh, that I've never put words to, but has been like a big thought in my mind, and I think a lot of other medical students' mind is, and I'm paraphrasing, but kind of just reminding you, think every time you're in lecture or every time you're in school, remember how many other students aren't there, and that your responsibility is to them, and kind of just taking that to your wider community as well. And I think we all, like, I know all these students that know somebody who should or could be in medical school, somebody that's smarter than us, somebody that's smarter than me, somebody that's like more, you know, has a better reason to be there. And there's this big sense of responsibility, and we don't tap into that as much. And one of those students that I can think of is a good lab partner from my undergrad just a year and a half ago. But she was she's Shoshone, and she's from the Wind River Reservation in Wyoming. She'll be applying like next year. Our financial situation is completely different. She didn't have a chance to apply to medical school as soon as I did. She didn't have a chance to pay for the preparation courses that I got to take. And yet she's brilliant. I loved working with her, and she's one of my closest friends I made from college. But one of the lessons that she taught me that also your talk reminded me of, Dr. Walsh, was that sending post-grad students to underserved reservations doesn't work very well. There's, at least from her experience that she told me about, was that a good chunk of her community doesn't go to the doctor that UW sends them, you know, just these students that can pay off their student loans if they work in this certain place for a certain number of years. And that kind of comes back to this concept that's been touched on tonight and that we talk about quite a bit, which is about a universal healthcare system or a single payer system. But from a student aspect or a student perspective, a lot of the time it just feels like kind of banging our heads against a brick wall and not getting anywhere further other than discussing the same injustices. And I guess I was wondering, to Dr. Walsh and to everybody here just conversationally, how has the conversation regarding single payer changed maybe over the last 20, 25 years? And where do you see it going is my main question. So sorry for rambling.
Not at all, Bryce. I think those are very good points. I mean, average medical student graduating debt load is in excess of $200,000. And those are for people who went to public universities. And in studies have shown that affects career choice. So when people are going out, they're faced with a mortgage that is 2 to 3 times the percentage rate is what you can buy a house for now. And that's starting to get a little bit of press, but not enough. And a lot of the politicians have made an art of how to get people to vote against their own vested interests. I keep a copy of this magazine on my bookshelf, which is 2004 October Harper's, where Louis Lapham wrote about the tentacles of rage. And that's the basic theory. How have they figured out to get these people to vote against their own interests? And it's a compelling and frightening story. And how do we reverse that? I think a lot of things, medicine should be a public utility, just like electricity used to be. And we saw in California what happens when you turn that into a profit-making organization and you don't do the maintenance. I think that the rural electrification project of the future should be broadband internet to all of these people in remote areas. They've all got satellite to watch worldwide wrestling and any kind of movie that has glorifies violence. So I think there's some work to be done, but until our society decides that you can't monetize and quantify every single thing as a marketable commodity, we're not going to be able to stem the tides. I think the population is starting to move in that direction, but politicians are still stuck in this vicious cycle of all the time making money to support their campaign. So we got to break those vicious cycles. What about the consolidation of healthcare by many of which are alleged Catholic conglomerates? Maybe we need to get Pope Francis on our side to say, as they say in South America, basta, bastante, enough. Where are we going to go with that commercialization and consolidation of healthcare? And many of the people who are hardliners for a complete national health system, like the Indian health system, like the VA, say that single payer is only just one step, and maybe these consolidated entities are going to take advantage of that and laugh all the way to the bank. So I just throw that out. Kevin, you got a comment?
I think you're much too pessimistic. If you look at what's happened in the last 5 years in single payer popularity, Medicare for all, it's in the news all the time. Polls show that even though they might not understand it completely, that 65% of people are in favor of the government guaranteeing health care. Even physicians and practitioners are over 50% in favor of it, and they're seeing their lives getting worse and worse, and suicide rates are going up, and healthcare professionals. And Pramila's got more supporters on her bill than ever before. Popularity of Bernie Sanders with the younger people. So I'm not at all pessimistic, and I think we're making progress. And I think what happened yesterday is going to help us along also.
I know, the places that you've been sound quite frequently a little bit violent sometimes. How much do you have to serve as a sociologist or like a community psychiatrist or, down in Eugene, they've had for 30 years, I think, something that other services than the police to dispatch to locations that have basically health problems, mental health problems or family disputes. And we might not have seen this Brooklyn City, the other Minneapolis killing going on. And I know San Francisco is trying to do the same thing where they have just started kind of a community health patrol that some of their stats are like upwards of a quarter of call outs that police go to, or even more are for ones that you don't require guns to be pulled out. I don't know if in your community experience, whether you've seen where you have to play that kind of role.
First of all, I wanted to thank Bryce for talking about just the barriers for minority groups getting into med school. He mentioned someone who was a lab partner of his from the Wind River Indian Reservation. I had a lab partner, and I'm from Wyoming, and I got into school through the University of Washington. But I also had a lab partner who was much more compassionate than I was. He would have made an amazing doctor, and he struggled because he was not as financially stable as I was. He had to work his way through school, and I didn't, and he just couldn't do both. So I think that really is an issue. But more to the point about Medicare and Medicare for all, was talking about the fact that people sometimes don't want to work in rural areas because there aren't incentives to. And I actually, I did a public health project this summer on that in Republic, Washington, or Ferry County, Washington, about access to home health services. And there weren't incentives to do it there. But a lot of the barrier to incentives wasn't just money, it was also policy-based. And it might not necessarily be fixed by, just Medicare for all. And then I experienced the same thing recently with a case on my current rotation wherein a Medicaid case, Colorado Medicaid, is struggling to get coverage for medications that they need to, recover from addiction, or for psych stays to recover from addiction, because Medicaid won't cover it. So basically what I'm just saying is I agree that Medicare for all is a first step, but the way that I present it when I present it to people is like this. Right now, we are dealing with, across the country, hundreds of insurance companies. We're fighting every single one of them for the services our patients need. But if we fight and we organize and we get Medicare for all, we get these services through this one program for everyone, yes, some of those financial barriers will still be there. The government's still going to be like, I don't want to pay for that. I don't want to pay for that. I don't think that's justified. But instead of like thousands of doctors across the country fighting hundreds of insurance companies, we'll be thousands of doctors across the country fighting one or a couple of insurance agencies. So my big like pitch for Medicare for all, when I try and sell it to people who, you know, maybe aren't on board with the economics, is I just tell them, do you want to fight 100 insurance companies and get nothing for your patients? Or do you want to organize with all of your fellow physicians to fight one insurance company and get them to make the change we need?
Thank you. And thank you, Larissa, for that. That's a good speech. And I also want to address what Bryce had to say, though. It seems like, okay, so we need so many new doctors, especially if we have Medicare for all. We'll need to roll out more services to more people and the demand will go up. And at the same time, we have doctors, young people that are wanting to become doctors. So what is there that Physicians for a National Health Program, for example, can do to change that system where the places for education in medical school are so limited? Is there anything that the physician community can do to change that and make more places available?
That's a great question, Marcia. And in some of the prior healthcare reform bills, there were stipulations for better healthcare planning because the pipeline is so long, right? From undergraduate to medical school to residency, that's a 10-year-long pipeline. And it demands planning, and to leave it to the whims of the market has been a disaster in the past. You look at the anesthesia match about 20 years ago, it was an absolute disaster. So I think there has to be better planning. There is going to be a surge of need. Kevin, you had a comment?
I've worked with physician assistants and nurse practitioners and registered nurses who I thought were as intelligent and as insightful and as compassionate and as dedicated as I was. I feel like the notion that we necessarily need more doctors might not be the answer, probably because of what Hugh said, the length of time it takes to ramp up. I think we can mentor the paraprofessionals around us and the clinical staff around us, and we can be champions of developing within our clinic, our practices, workflows that let people work at the top of their license. Because I know that at my own clinic, hardly anyone is working at the top of their license. I'm not even working at the top of my license because I have to spend so much time basically doing clerical things because there's no one else to do them for a patient. We need more people to take care of patients, but I don't know that we need more doctors.
Well, and they always used to remark that every new doctor generates $660,000 worth of new billing, regardless of the services they provide to a certain extent. So there's that counter argument that's been used. Sarah, you had a comment?
I mean, I'm a general internist, right? An old-fashioned primary care general internist, ICU down to don't ask me to deliver a baby or do operations. And we have been systematically underfunded since the mid-90s because the payers can't figure out what we do. And so, surprise, surprise, I agree with you, Dr. Walsh, and I have worked in many, many clinics with nurse practitioners and PAs and taught them and mentored them to, one would like to think, to the top of their performance. But at the end of the day, you need a physician to help them it just gets too complex. Irregardless of the incredible administrative burden that's been dumped on all of us over the years. And now general internal medicine is a dying profession. I mean, everybody asks for internists, but how many people do you know that go into general internal medicine or go into even general family practice without doing OB or some surgical stuff to bring in some more revenue, who don't quit out of incredible financial frustration. What's so discouraging to me is to see my young associates and my medical students and people I've worked with through various educational things over the decades say, I just can't do this anymore. It's too exhausting. As you said, Dr. Walsh, raising a family, trying to juggle all that, paying back their loans and being paid peanuts to take care of everybody else's problems, because still now to this time, and we talked about this in previous meetings, the rallying cry of every specialist in the American healthcare system still to this day, and I will entertain comments from my colleagues here, is, oh, I don't do that. Go see your primary care physician. Am I right?
Well, if you look at the ratio of specialists to primary care people, we're like 20% primary care, and the rest of the world is like 70 or 80% primary care. So there's something that a sane system could do to make that balance out, because we definitely need more primary care people who are trained to do like C-sections or whatever in the rural clinics.
You have to pay primary care doctors, right, to juggle all the balls. And that is what stopped. We don't do as many procedures. We juggle all the stuff that our procedure specialists, God bless you all, colleagues have trained so hard to do. And we respect you for that. No one respects us with dollar payments for all the time we spend taking care of the people you discharge from the hospital.
That's got to be balanced, because people go into specialties because they need to pay back all the student loans and stuff. That's
right.
A major reason, and they've got families, so they need that money coming in.
And it's never going to happen because the private insurers cannot quantitate what we do. And that's when it all started going south. So
we're Medicare for all, right? Improved Medicare for all. That's, you know, I think we all agree here that that's going to solve most of the problems.
Yep,
we work on the delivery system, but the financing, once we get that in shape where there's no barriers to care, people who work in institutions are on salaries, and institutions have global budgets, and the individual docs who have their own office or whatever, their payments negotiated on a regional basis by their specialty group and so on. So that's the same way to do it.
You know, I got a couple things. First of all, you can make college free, you know, and that will help a lot with that disparity. But in these days of trauma, I just Google searched for legislation. All I could find was CDC reports on the public health crisis of gun violence. So as far, you know, maybe PNHP can find the legislation on measuring the health crisis from guns. And I found that article from Ralph, and it was John Guyman who wrote this pamphlet on Medicare for All.
Right. Yeah. Thanks for sharing that. That's a great reference.
It's in the chat.
John's a great guy. You know, Fred Rivera, who's a pediatrician here in Seattle at the UW and at Children's, and a chief for a long time at Harborview, was just given an award as the Pediatrician of the Year nationally. And Fred's major research interest has been in gun violence. And even with the, is it the Dickman Amendment that kind of froze federal funding for researching guns and gun violence, Fred went ahead and was able to get a grant from, I think it was King County and the city of Seattle, and they did some great research. So if you want to look into local and national work on gun violence, just look up Fred Rivera and his work. He's done some amazing studies. Some of them, you know, and it has to do with one of the more recent studies was people who get into that culture of gun violence. It's pretty self-perpetuating, but surely that's one thing that we need to address as well. David, you know Pramila Jayapal's bill, what is an HR 1976? Better than...
Nice number.
Yeah. better than anyone else. I know that it was either McDermott's bill that was on the docket for a long time, Jim McDermott, or it was
John Conyers.
John Conyers, thank you. The patron saint for you medical students, the patron saint of the 80-hour work week is, in fact, John Conyers. In one of those bills, they had a very well developed outline for a reinstitution of the U.S. National Health Service Corps that gave a option other than the military for students for loan repayment, other than the military or the Indian Health Service and some of those others. And in that was stipulations for planning and proportioning appropriately of different specialties based on need, not the economics. And does Jayapal's bill have anything like that, David, that you're aware of?
I think it makes reference to it, but it hasn't been spelled out exactly.
Right.
But definitely, I think it's in there somewhere.
Fitzmullen, who was on that Cuba trip with us, he's also, I think he's a pediatrician, was at George Washington, and Fitz used to be run the health service corps for the public. He was the assistant secretary or assistant surgeon general of the public health service at one time. Right. And Fitz was really big on that as well. Unfortunately, Fitz has also left us in the last year or two. There's obviously a lot of work to do on a lot of different fronts. I don't know if anybody else has any other comments or suggestions.
I would like to just pull together some thoughts that we've heard from several people. It's true that simply passing a healthcare financing system that covers everybody, like Medicare for All, does not solve all of the problems. But I like to think of it with two sort of one-liners. The first one-liner is it creates a platform that brings everybody to that platform, and then we can build an improved healthcare delivery system on that platform. And the other one-liner is first bring everybody into the tent, and then together we can build a better tent. And I think that the idea that it's at least a two-step process, first covering everybody, and then covering everybody for what, and how do we make it better, and having public ownership of it. Right now, not one of us here feels that he or she has any ownership of the healthcare system, even though many of us have devoted our lives to working within it. We do our best to cope with what's thrown at us, but we have no ability to grab anything and throw it back. How's that for another one-liner?
The antidote to despair is activism. So that's what we're doing, right?
I too would like to thank you, Hugh, and Kevin for addressing the rural health issues. We see a lot of disparity in outcomes from healthcare as a general rule, and especially during this pandemic. I wanted to share one thing, which was that Bob Lutz and Amber Lenhart from Eastern Washington, public health experts, are going to share some inequities related to the recent COVID issues that have just highlighted some long-term effects, some long-term inequities that have affected our healthcare system. They're going to speak on May 12th on a Healthcare for All Washington Zoom call. You all are invited to join that and to continue to address some of these underlying issues like David McClanahan brought up and helped refocus this meeting. But my question to Kevin is, who is out there trying to correct some of the inequities in rural health? You talked about your obstetrics and child emergency care, but there's all these other emergency or specific services that are needed in rural health. Do you know what organizations out there are interested in working with us and moving that forward?
I do not. You know, I do medication-assisted treatment now in the clinic I'm in, and feeling that I have is that there's a big population of people in our country who I think, as a result of the loss of manufacturing jobs, has basically become expendable. There are not a lot of opportunities for people if they stay in the community where they've grown up. No, I don't know of anybody who's approaching this in a systematic way.
Ronnie, Healthcare for All Washington put on a great webinar, was it last week with, was it Belk, Richard Belk? Or
David Belk.
Because that was just astounding bunch of information there about how the insurance companies are very happy to see the prices rise because they get a bigger chunk out of raising prices. So they've got an incentive to connive with whoever to raise medical costs.
Yeah, that's right, David. This is Marcia. I just wanted to let you know that Dr. Belka is working on editing the video. He said he wants to take out the ums and the ahs. He's going to send it to us when he's ready, when he's done with that, and that'll be after this weekend sometime. So we'll have it up there as soon as we can get it back from him.
One of the best ones in a long time.
Yeah.
If anybody can share those links or resources with us in the chat, that would be helpful too. And maybe Kevin, we can put that that telomere length and social determinants of health article out of the Lancet that you sent me. That's a great review article. And it's one of a series of 3. David reminded me that the PNHP kitchen table series, which I wasn't aware of, and I went through and reviewed that on Rural Health Today. There's a wealth of information in there. There's some great articles by the CDC. George, you're looking for data. There's some great data and great tables, and too bad the people that wrote Medicare for All didn't include some of those in their book, because they illustrate quite well what the situation and the problem consists of.
I think, in all fairness, I'm reading almost all the way through now the book by El Sayed and Johnson on Medicare for All, A Citizen's Guide. It's not, the purpose of that book is not to snow people with tables and charts of data, but to explain things to people who would be put off by tables and charts and data, and who would close the book and not pick it up again. So the different books have different audiences and purposes. And so
he also does a podcast regularly, I think weekly. El Sayed does. He's an amazing guy. He's from Detroit, ran for governor, didn't he? And is MD, MPH, and he's on the faculty at Wayne State or Michigan, one of the two. Pretty incredible.
He's a health commissioner for Detroit, wasn't he?
Yeah, that's right.
Anyway, it's a good book. As somebody who's been up to my eyeballs in healthcare and single payer healthcare reform for 35 years, there's not much in there that I didn't know already. It's just, so when I'm looking at it, is the way it's presented, and in getting and being readable for somebody who doesn't start already knowing everything that's in there. So I recommend it, but we're all pretty knowledgeable. The intended audience is the more general public. The people who you used to meet when we actually had parties, who would say to me, "Oh, what are you doing now that you're retired?" And I would talk about being an advocate for Medicare for All. And they would say, "Oh, that's just so important. We really ought to have it." And then who do you like in the National League? And the conversation moves on, because it doesn't really bring them in to engage them. But I think they're all out there ready to be engaged if we can find a way to, or something for them to get behind.
And Kevin, this is pointed to you. Retirement is good, but you never get a day off.
That is so true. You will be busier than ever in retirement. Trust me.
It only costs $1,800 to get on the ballot for the U.S. House of Representatives in the state of Washington. I know, I did it. I got 2,300 votes on planetary peace, audit the military, Medicare for all. You could take 3-star young stars with $600 each and make a team, go on the ballot as a team, you know, and just, but, you know, you don't need party affiliation. When Biden says he's going to veto it, we need a veto-proof majority. We need to bump Dan Newhouse. For rural health, you know, the things he says are shocking. And Kim Schreier, we can do better. You know, she did not take Medicare for all as her banner, but only $1,800. God, you guys got to know somebody, you know, and just front them the money, and then you get them in the voter's guide, and you get, you know, that into every mailbox. And you can't buy that kind of publicity. $1,800 to get in every voter's box.
My son is speaking right now, probably, at the 41st Legislative District Democrats, which meet on the same third Wednesday of every month. So I never get to go to them. He has thrown his hat in the ring to run for city council here on Mercer Island. So if any of you are Mercer Island voters, vote for Ted Weinberg. But anyway, he needs more than $1,800 just to deal with being taken seriously as a candidate for city council on Mercer Island. We just require way too much money to run for office. And in a way, that's a whole nother issue, but it impacts us.
Colin Romero, what are you doing these days? One of the heroes of the past.
I just retired. I was working for the health department for a while.
You worked until you were 80?
I'm only 75, so I just retired completely a few months ago. I was just doing administrative work for the last year anyway. I am completely retired, and as of the last 2 months, I've had so much to do around the house and the yard and everything else. I haven't had time for much else. I appreciate checking in with you guys. It's really been helpful. Thank you. And Kevin, it's good to see you.
For the rural stuff, again, I'm a WAMI student, University of Washington, Wyoming, Alaska, Montana, Idaho program student. I'm from Wyoming. Being a WAMI student, I think that program is absolutely the best in the country for incentivizing, and it is primarily primary care, which is what we need, incentivizing people to go to rural communities, but also for helping people from rural communities like me. I'm from Worland, Wyoming, a town of like 4,000 people known for sugar beet farming. And I'm the first one from my school to even go to the Wyoming version of this, or from my town. I just think those sorts of programs, if we could encourage those more across the country, programs that do two things, and it's both recruit, and this is the more important one, deliberately recruit from smaller rural areas and then incentivize return to those areas. I think that makes a really big difference. I've seen it in my community here in Wyoming, how big of a difference like that University of Washington program really does make on correcting some of those disparities. And it can't correct them all because, you know, money is an issue, but I think it really does help just deliberately recruiting and incentivizing people from smaller areas that want to go back and serve their hometowns to go to med school instead of making it harder for them.
Thanks, Larissa. That's great. Hailing from 30 miles shy of the Wyoming border in western Nebraska, also a sugar beet raising place in the Platte Valley. You know, Frances McDormand might get an Oscar this week for her role where she played someone working at the sugar beet factory in Scottsbluff, if you've not seen Nomadland. Oh, yeah. So sugar beet factories are going to be famous here just in a week, I swear to God.
They still won't ever understand the smell.
That's a great movie, though, in terms of social determinants, too. If you've not seen it, it's an amazing film. Merle, go ahead.
Oh, I was just going to say to Sherry that Mercer Island just recently passed laws, which I think like 60% of your small towns are all passing. And this probably has major health impacts, at least for Seattle, is they're closing up their opportunities to be out there in affordable areas for people to sleep outdoors or to, get their, even be laying down in the street. So, you know, they have 12 people who are in different parks there in Mercer Island. And when they close those places up to the houseless, they are essentially having those people come to Seattle because this is where all the services are. And I don't know if that happens necessarily in sort of that would advantage people who are houseless. And maybe you could speak to what kind of a platform your son has.
That is not his platform. Does not include that. He is a progressive person, but the problem is, what do we do with people camping in homeless? They need services, and those services are not available on Mercer Island. There's simply not the volume to do it. So I think there's a deal going with Bellevue, and they are helped to go to a shelter or some kind of housing or temporary housing in Bellevue where services are available. That's my understanding anyway. It's not being criminalized. It's just that you're not allowed to do it. So you need, and we will help you to find something else if you're living outdoors. It's a
well, they're criminalizing it. They're criminalizing it.
In Santa Cruz, California, the homeless advocates got to a federal judge who determined that sleeping is not a behavior. It's a condition of being human. You can be a human anywhere. You can sleep anywhere. And it was a federal decision. But, you know, that's the fact of it, that it's not a crime to sleep. Of course, where you're going to litter all your gear, what your belongings go, is a little different than where you take your body.
Well, I would say the whole issue is a work in progress. We're not trying to criminalize being homeless, but finding a way to get people who are homeless connected with the services that they need, including shelter, is a social responsibility. And that's the job of local government to make it happen. Anything for the good of the order.
So I think I finally was able to make the PNHP.Washington@gmail.com. I couldn't figure out how to do it for Comcast, but that's our new address, although the Comcast Western Washington will still work for a while.
Right, I didn't emphasize in my introduction that we have recently switched from being Physicians for a National Health Program Western Washington to being Physicians for a National Health Program Washington chapter. And we are anxious to include and invite as many people as possible outside of Western Washington, yes, but just reaching out beyond the population centers around Puget Sound and into the rest of the state. So any context that you have out there of people who you think would enjoy being part of our chapter, especially while we're all still meeting by Zoom. You don't have to drive across the state and over the mountains in order to attend a meeting. And we don't have to drive over the mountains and across the state to attend a meeting over there either. We can all just make use of our forced electronic meetings to take advantage of the situation.
Yeah, I think it would be great if we could have the SNAP chapter in Spokane put on a program for us. Although I think they're just getting organized now, but there's two medical schools in Spokane, you know, the Washington State one, university too. So there's
right.
One of the goals of our chapter is to develop these contacts. There are 162 currently dues-paying members, PNHP national dues-paying members. And if they're currently up to date in their dues, that means they're probably going to be open to at least being contacted. So that's what we're going to do. I'd say 2/3 of those folks are in the Seattle area, but there are plenty on the other side of the mountains in southwestern Washington too.
Okay. Well, thank you, Kevin, so much.
You want to say something, Kevin?
Yeah, well, first of all, thank you all for the invitation and the conversation. I appreciate it. I want to put in a plug for a book, and the title of the book is The Sum of Us, S-U-M. The author is Heather McGhee, M-C-G-H-E-E, and she talks about how the basic paradigm of hierarchy damages society, traces its effects through the history of America, but then offers some opportunities for thinking in a different way. And as I've been challenged to reach out to conservative neighbors in the community where I live in rural Washington, it's been a challenge for me to imagine how to find common ground. I think that we all, as privileged physicians, many of us who have successfully reached retirement, have a nice opportunity to maybe broaden our language in a way that can reach out to folks who don't see social forces the same way we do, who don't see society's challenges the same way we do. Maybe be able to speak to them in a way they can hear. It's not easy, but it seems to me maybe a constructive role that we can play. But again, thank you all for the opportunity. And one more time, thank you to Hugh, and thank you, Colin, for being compatriots in the struggle.
Thanks, Kevin, very much. Nice to see you all.
Okay. Yeah. Thank you.
Thank you, Kevin.